All right, we're going to talk about abnormal uterine bleeding. Go through the words that we use, etiologies, evaluation and workup. And what isn't in your handouts, I have a case that was very interesting that I took care of just in the past 3 to 4 months that I thought I'd share with you that would give you some insight into management of abnormal uterine bleeding. Now, normal bleeding is mean interval every 28 days, plus or minus 7 days. Obviously, if a woman's used to 3 to 4 days of flow and she flows for 5, that's abnormal for her, even though it falls within the normal ranges. More than 7 days flow technically is abnormal. Average blood loss with menstruation is about 30 to 50 cc's. Anything over 80 is considered abnormal. 95% of women will lose less than 60 cc's. Now, these are values that have been garnered from studies in which they've actually taken sanitary pads, extracted hemoglobin, and come up with a value. If you've noticed, they don't dispense Erlenmeyer flasks with sanitary napkins, so women can't tell you exactly how much they've bled. Menorrhagia is prolonged bleeding greater than 7 days or 80 cc's, and it occurs with regular intervals. That would be menorrhagia. Another term is also hypermenorrhea. Menorrhagia occurs in about 15% of healthy women. It's not unusual. Metorrhagia, on the other hand, is uterine bleeding occurring at infrequent intervals. And combine the two, menometorrhagia is prolonged uterine bleeding that occurs at irregular intervals. Oligomenorrhea is infrequent uterine bleeding varying between 35 days and 6 months. And of course, amenorrhea is no bleeding for more than 6 months unless you have a teenage daughter, and anything more than 35 days would be amenorrhea. And this study is frequently referred to. 40% of women with blood loss greater than 80 cc's, significant bleeding, considered their flow to be small or moderate. Those are the patients you want to have in your practice. 14% of women, these are the ones you seem to have, with less than 20 cc's, thought their flow was heavy. So it's all over the page. Follow-up study, approximately 14 years later, 1/3 of light menses were actually greater than 80 cc's, and 1/2 of those who believed their flow to be heavy, it was less than 80 cc's. Etiologies. Organic etiologies, and you have dysfunctional etiologies. Organic etiologies of abnormal uterine bleeding fall into systemic, reproductive tract pathology, and then iatrogenic. Those are the organic causes. Dysfunctional bleeding is either ovulatory or anovulatory. Everything falls into those groupings. Systemic etiologies would include coagulopathies, patients with leukemia, things of this nature. ITP, idiopathic thrombocytopenia, would be a systemic etiology for abnormal bleeding. And thyroid dysfunction, not an uncommon cause of abnormal bleeding, particularly as a woman approaches the age of 50. Now, this study in 1981, in a 9-year review of 59 cases of acute menorrhagia in adolescents, usually 11, 12, 13-year-old who's just starting menstrual flow, it was found that 20% of those had a primary coagulation disorder, as opposed to an older woman where that wouldn't be the case. Therefore, routine screening for coagulation defects really should only be reserved for the very young patient who has heavy flow with the onset of menstruation. Von Willebrand's factor VIII is the most common inherited bleeding disorder. It has a frequency of about 1 in 1,000. So you will encounter patients that have bleeding issues with a factor VIII problem. The question was, what other ones might you see? Inherited hemophilias, for instance, but that would have manifested itself much, much before then. Now, as I mentioned, hypothyroidism can be associated with menorrhagia or metorrhagia, one or the other, and the incidence is a lot more than you might realize, 1 to 2.5%. Not uncommon to find that. Now, the most common causes of reproductive tract abnormal bleeding, if you break it down into premenarchal patients, reproductive age patients, and postmenopausal patients, in the premenarchal patients, it'll be a foreign body. And the most common foreign body would be toilet paper in the premenarchal. In the reproductive age woman, by and large, the most common cause for abnormal bleeding is a gestational event. She's pregnant. Whether it's a normal pregnancy is yet to be determined, but she can be pregnant. Even if she's had a tubal, if she's 18 living at home and her mother assures you she can't possibly be pregnant, it's possible. And in a postmenopausal woman, the most likely cause of abnormal bleeding is atrophy. Now, in looking at the reproductive tract causes of abnormal bleeding, you can have gestational events, malignancies, and benign causes. Within the benign causes, you'd have atrophy, fibroids, polyps, cervical lesions, foreign bodies, or infections. Those can all result in bleeding of a benign nature. But the one thing that we want to eliminate as a cause would be malignant and, of course, a gestational event. And those gestational events would include ABs, whether they be spontaneous miscarriages or bleeding as a result of an elective AB, ectopic pregnancies. One of the classic symptoms of a woman with an early ectopic pregnancy is abnormal bleeding. Trophoblastic disease, if she has hydatidiform mole, something of that nature, even though it's rare, will have significant bleeding. And an IUP, intrauterine pregnancy. 6 to 7% of all intrauterine pregnancies, normal intrauterine pregnancies, will have some bleeding. Sometimes it's implantation bleeding, other times it's just bleeding that happens. In terms of malignant processes, it's very logical. There's only going to be 3, maybe 4 sources. Endometrial cancer would be the most common. Ovarian cancer would certainly manifest as abnormal bleeding. Along with that, very rarely, you might have a tubal carcinoma that would manifest as bleeding. And then, of course, the one that we would immediately think of would be cervical cancer. Rarely, you could have a vaginal cancer, but by and large, if it's a malignant process, it'll either be endometrial, ovarian, or cervical. We know that 10% of women with postmenopausal bleeding will ultimately be found to have endometrial cancer. It's only 10%. And an equal number will have hyperplasia. So 10% will have a malignant process, 10% will have hyperplasia. Now, this just shows you what the incidence of endometrial cancer is in premenopausal patients. And it's important to note the trend here. Very, very rare in a young woman, 30 to 34. 2.3 per 100,000. It does happen, though, and I would submit that probably in the next 20 to 30 years, when the obesity problem in this country catches up with itself, this number will increase significantly. In the 35 to 40-year-old, 6.1 per 100,000. And this is where the big jump takes place. In the 40-year-old woman, 36 per 100,000. So it's in the 35 to 40 age group that we need to be vigilant about the possibility of a malignant process being the etiology for abnormal bleeding. And I'll get more to that as we talk about sampling and so forth. Benign causes. Atrophy, by and large, the most common cause in a postmenopausal woman. Fibroids, classic offenders for abnormal bleeding. Polyps can result in bleeding. Cervical lesions, not uncommon. Foreign body and infections. The most common foreign body in an older woman would be one of 2 things: intrauterine device or a pessary. Those would be the most common foreign objects. And of course, infection, cervicitis, endometritis. 60% of postmenopausal bleeding will be a result of atrophy. Remember, 10% would be malignancy, 10% would be hyperplasia. Hyperplasia may be a premalignant, may have a premalignant aspect to it, but there's your 100% in a postmenopausal woman. Women that have fibroids, there's certain reasons why, aside from the fact that there's a fibroid within the uterus. There has to be an increased number of vessels to sustain the leiomyoma. That will result in increased bleeding. There's obviously an increase in the endometrial surface area. If that happens, you'll have increased flow. The uterus does not contract as effectively or efficiently with a fibroid, so you're not able to clamp down on the spiral arteries, which would result in decreased bleeding. And for some reason, clotting is less effective locally when there's fibroids. And fibroids are also associated with an increased amount of rapid flow or gushing, if you will. Iatrogenic causes would include an IUD, oral or injectable steroids. If any of you have ever given Depo-Provera, you've probably told them, 50% are going to have abnormal bleeding. And what invariably happens? They didn't hear that, they didn't process it, whatever, and they call you up and say, I'm bleeding all the time. Most common cause for that would be just the steroid itself. Psychotropic drugs can also result in abnormal bleeding because it will disrupt the hypothalamic pituitary axis and result in some abnormal flow. Not of a pathologic nature, but something that brings them to call you or seek your advice. Now, dysfunctional uterine bleeding, it's actually an older term, but it's still in wide usage. It's not improper to use the term, but it's actually abnormal uterine bleeding for which an organic etiology has been excluded. So if you go through the steps, rule out a pathologic process or a cause, fibroid, polyp, iatrogenic cause, medicine, whatever, then you say the patient has dysfunctional uterine bleeding. Once you've determined that, then you need to determine whether it's anovulatory or ovulatory. Is the patient ovulating or is she not ovulating? The lion's share of these women, or the lioness's share of these women, will have anovulatory cycles resulting in the abnormal bleeding. It's very simple to determine if a woman's abnormal bleeding of a dysfunctional nature is ovulatory or anovulatory. You go by history. Obviously, if a woman's cycling and she's ovulating, she'll have cyclic flow. It doesn't necessarily have to be every 28 days. It could be 26, 30, 28, 32, but generally there'll be some cyclicity to it. If they are wanting to achieve a pregnancy, or if you want a real easy way to tell and you have a highly motivated patient, you can get daily basal body temperatures, and that'll help determine whether or not she's ovulating. And what will happen is she'll have a basal body temp that'll be consistently 96, 97 degrees, and then with ovulation, the temperature bumps up 1 degree and sustains through the secretory phase or the second half of the cycle. If a person does this, either to achieve fertility or to assess that, you can get a thermometer at any large drugstore chain that is graduated in smaller ranges, so it's a lot more accurate. Rather than going up to 104, it might be 95 to 100. So you get a wide scale so they can accurately tell if they've had a sustained 10-day length of increased body temperature. You can also get a progesterone level in the second half of the cycle, and you'll have an elevated progesterone level because of the corpus luteum. That will tell you whether or not a woman's ovulated. And you can also get an endometrial biopsy in the second half of the cycle, and your pathologist will tell you if you have a proliferative endometrium or a secretory. If you have a secretory endometrium on a pathology sample, the patient has ovulated. That's what the pathologist sees when ovulation has transpired. And as I mentioned earlier, the majority of dysfunctional abnormal bleeding in a premenopausal woman is a result of anovulation. She doesn't release an egg, so she bleeds. And I'll go through the pathophysiology of that and make it very understandable. Now, we're going to go back to basic science a little bit, but it will really help you understand this. With anovulation, if a woman doesn't ovulate, the corpus luteum from the Graafian follicles in the ovary is not produced. Therefore, the ovary fails to secrete progesterone. So, no ovulation, no corpus luteum, no progesterone. That's it in a nutshell, and you can figure it all out from there. However, estrogen production continues. This is why you have overweight, obese women who are anovulatory that have abnormal bleeding, because they still produce estrogen. The estrogen still attacks the lining of the uterus, the endometrial lining, and it proliferates and results in breakdown bleeding or abnormal uterine bleeding. Now, I'll stipulate these two facts. PGE2 results in vasodilation, and PGF2 alpha results in vasoconstriction. Those are facts. That's the way it happens in our bodies. We know through the cyclooxygenase pathway that progesterone is necessary to increase arachidonic acid. That's part of the pathway, which is the precursor to prostaglandin F2 alpha. Now, because the progesterone's decreased, you have decreased PGF2 alpha, which would lead to decreased vasoconstriction. So if you don't have vasoconstriction because you've altered your PGF2 alpha PGE2 ratio, you will then have, or she will then have, abnormal bleeding. That, in a nutshell, is the pathophysiology that leads to anovulatory bleeding. And since vasoconstriction is promoted by PGF2 alpha, which is less abundant due to the decrease in progesterone, due to no corpus luteum, due to no ovulation, vasodilation results, and you have abnormal uterine bleeding. All right, so what do you do with evaluation and workup for an early reproductive patient, adolescent? Obviously, you want to get a thorough history. Include a family history. You want to find out what the factors were or what the history was of her first menstrual cycles. Screen for an eating disorder, because that can result in all sorts of issues. And the labs you want to get, of course, would be a CBC, PT, PTT, bleeding time. Despite what her mother tells you, you want to get an HCG. You definitely want to rule out a gestational event. Now, this is a departure from what you might commonly think or what we would have been taught in the past, but this is definitely a change. It's official policy by ACOG, American College of Obstetricians, back to 2000. You should consider an endometrial sampling for adolescents, 17, 18-year-old, with a 2 to 3 year history of untreated anovulatory bleeding in an obese female less than 20 years of age. So if she has unopposed estrogen for more than 2 years and it hasn't been treated with a progestational agent in some form, you should consider an endometrial biopsy for that patient. And in our service here at the University of Nebraska, we have encountered women under the age of 25 with significant histology related to unopposed estrogen. Our big fear years ago used to be that woman who fell through the cracks. Somebody else was providing estrogen without progesterone. She still had her uterus. She comes in with abnormal bleeding, and you're thinking, oh my goodness, I hope this isn't malignant. Those patients still happen, but it's these patients that we really need to be vigilant about. Now, if a woman's of reproductive age, still you want to get an HCG, still want to rule out a gestational event, even though her husband may have had a vasectomy, even though she may have had a tubal. Tubals can fail, vasectomies can fail, and Patients can have extramarital relationships. You still need to secure the HCG. You want to get an LH of an F and an FSH to determine if she's premenopausal or postmenopausal. And of course, you want to get a CBC. Have an idea what her blood count is. That'll help determine how rapidly you need to do things and so forth. Cervical cultures would be helpful because if there's a cervicitis due to a sexually transmitted disease, you can treat that and the bleeding will resolve. Ultrasound is very helpful. Hysteroscopy may be necessary. That's very easy to do. Some can do it in the office. That's simply a womb with a view. And endometrial sampling. If you're not doing endometrial samplings, I would urge you to do them. They're very easy to do. They're very safe. I'll show you the numbers. It'll give you a significant amount of information that will help you. In a postmenopausal patient, you still want to get an FSH and an LH because you want to confirm that the patient's postmenopausal. Transvaginal ultrasound is extremely helpful, and I'll show you the data related to that. Always, always, always consider an endometrial biopsy. That's, as I said, if it's something you're not doing, I would urge you to learn. And hysteroscopy with endometrial sampling, and I have a question mark there because new data has suggested that that may not be the wisest thing to do in a postmenopausal woman, because if she has an underlying malignant process and you do hysteroscopy, which involves increasing the pressure within the uterus, you could cause malignant cells to spill out through the fallopian tubes, thereby contaminating the peritoneal cavity and potentially upstaging a malignant process. So this is somewhat of a, it's in flux, but one needs to be careful in reflexly doing hysteroscopy in postmenopausal women. Now this that I'm about to share with you is an ongoing study, and up until 2 or 3 years ago, we didn't have any long-term follow-up. But as it relates to transvaginal ultrasound, I think you'll find it helpful. Endometrial cancer, as I noted before, is found in about 10% of women with postmenopausal bleeding. If a woman does have that, she has a 64-fold increased risk of developing endometrial cancer, even though she initially might not have that. In this body of work that was reported in 2003, they found not a single case of endometrial cancer with the endometrial stripe width being less than 4 millimeters. Now, the endometrial stripe width is nothing more than a sagittal view of the uterus, and you measure the anterior wall of the endometrial lining juxtaposed to the posterior, and you measure the two. In Dr. Gull's work, they found that if the endometrial stripe is less than 4 millimeters, they didn't find a single case of endometrial cancer in their 10-year follow-up. These are the only people to report 10 years of follow-up. I caution you, however, though, that they only had an N of 269, but it's encouraging. And it does have some applicability in certain clinical scenarios. They also found that there was no increased risk of endometrial cancer or atypia in those women who did not experience recurrent bleeding. The role that this may play is if you have a woman who has a single episode. Now, have any of you read The Alchemist? It's a wonderful read. On page 156, he has a quotation that goes, "If something happens only once, it'll never happen again. But if it happens a second time, it'll surely happen a third." But if you have a woman who has a single episode of postmenopausal bleeding and your evaluation is reassuring and she has no more bleeding, if her endometrial stripe width is less than 4 millimeters, that's reassuring. However, that doesn't give you pathology, and I'll get into that a little bit. They also found, or as I said, they found no endometrial cancer if that endometrial stripe width is less than 4 millimeters. However, there was a 7.1% risk of endometrial atypia in those women with a stripe width less than or equal to 4 millimeters that had recurrent bleeding. And when you introduce atypia into the histologic milieu, then you start to increase your risk of invasive endometrial cancer. They did have 3 women with an endometrial stripe width of 5 to 6 millimeters with recurrent postmenopausal bleeding who were diagnosed with endometrial cancer within 3 to 5 years. So once you get beyond 4 millimeters, it can become an issue. Now, this was a very helpful study because we all have patients that are on hormone replacement therapy or are taking it and they experience bleeding. This is very helpful because Dr. Good showed that if you have an endometrial stripe width of 4 to 8 millimeters, but the woman is on hormone replacement therapy, that's a normal range. That doesn't absolve you from the responsibility of ruling out a pathologic process, but it certainly isn't an endometrial stripe width of 12, for instance, which could potentially be alarming. Yes, sir?
How about people who are on aromatase inhibitors, like Arimidex? I have a patient who's constantly 6 millimeters, been 6 millimeters
as long
for some
as you've
time.
sampled that woman, there are no data that I'm aware of specific to that drug. But as long as you sample her and you're following her along, I think that's reasonable. Now, endometrial biopsies. Complications are rare. Perforations are rare, about 1 to 2 per 1,000. Infections and bleeding are even rarer. They're very easy to do. With the use of Cytotec, you can sometimes get a stubborn cervical os to soften to the point where you can achieve a higher success rate of negotiating the cervical os, particularly in a 40 to 50-year-old woman. And if you're going to use Cytotec, of course, you want to absolutely make sure that she's not pregnant. And you would use 400 micrograms would be fine. She can take that orally. Sensitivity of an endometrial biopsy compared to the DNC is about 90 to 95%. As I said, it's easy to perform. There are numerous sampling devices out there. Whatever you become comfortable with, just use it. I show this slide again to emphasize the fact that starting at the age of 35 to 40, the risk of endometrial cancer goes up to 36 per 100,000. That's why we as OBGYNs recommend endometrial sampling for women over the age of 35. It would be a deviation from the standard of care if you did not follow that age 35 guideline. Now, endometrial cancer is the most common genital malignancy. Incidence is about 1 in 50. You will find it, particularly as our aging women become heavier. This 4th most common malignancy after breast, bowel, and lung. 34,000 new cases annually with greater than 6,000 deaths annually. The risks for endometrial cancer, nulliparity. If a woman's never been pregnant, increases her risk 2 to 3 times. Diabetes, 2.8 times, and that goes hand in hand with the weight issues. Unopposed estrogen increases the risk 5, 6, 7, 8 times. Weight gain, 20 to 50 pounds, which would capture just about everybody, it seems, 3 times. But if she's had greater than a 50-pound sustained weight gain in her lifetime, 10 times increased risk of endometrial cancer. Now, you get an endometrial biopsy. What are your reports going to show? How do you ferret that out? You'll get proliferative. That's a benign process. That means ovulation hasn't happened yet. Secretory, benign process. That's what happens after ovulation. They might report benign or atrophic. You might get inactive. That's fine. In a postmenopausal woman, that's what you'd expect to see. Then again, you might get tissue insufficient for evaluation. So then your options are to attempt repeat sampling if she tolerated it, or to proceed with a DNC. And you might get no endometrium seen, which puts you in the same group. You might get a report that shows simple or complex hyperplasia without atypia. That's a benign process. You have a proliferation of the lining of the uterus, but there's no atypia associated with it. That woman needs to be managed with a progestational agent, but it's not alarming. Now, if you have simple or complex hyperplasia with atypia, the alarm should start going off that there's possibly an underlying malignant process and you just got part of it, and that's the patient that you're going to want to refer to either a GYN specialist or gynecologic oncologist, one or the other. And of course, you might get a report that shows outright endometrial cancer. Now, hysteroscopy is commonly used, and it was previously considered the gold standard. The advantages of hysteroscopy are you have intervention at the time that you're actually visualizing the lining. So you can remove a polyp, you can remove a fibroid lesion, whatever you believe to be causing the bleeding, you can deal with it at that time. But recent reports have shown that you can have positive peritoneal cytology, positive cancer cells within the abdomen in endometrial cancer who have undergone hysteroscopy. That's why we're not quite sure exactly what role this should play in postmenopausal women with a high index of suspicion for a malignant process. And in fact, in this study from 2004, they took 256 patients with endometrial cancer. 204 were found by either EMB or DNC, and 52 were diagnosed at the time of hysteroscopy. So those were the two arms. In the EMB-DNC arm, 6.9% had positive peritoneal cytology at the time of the staging procedure to manage the endometrial cancer, whereas in the group that had the hysteroscopy, they had 13.5% positive peritoneal cytology, and that achieved statistical significance with a p-value of 0.03. However, what is not known is, does that change in staging affect long-term prognosis? Initially, they thought it would, but they're not quite sure if that's the case. Now, management. What do you do to manage a woman with abnormal bleeding? Well, obviously, prior to initiating therapy, you need to ask yourself a couple of things. One, rule out a pregnancy. Again, despite what the patient's mother might say, if she's had a prior tubal, husband's had a vasectomy, that sort of thing, HCG test is worth its weight in gold. And you want to make sure that the patient doesn't have an underlying malignant process. It would be very inappropriate to initiate a course of hormonal therapy in a woman that you have not excluded a malignant process. And don't overlook the fact that a woman could have breast cancer, and you need to make sure that you're vigilant about mammograms and so on and so forth if you're going to manage abnormal bleeding. Now, your management options. What do you have available to you? Well, you've got progestational agents, you've got estrogen, oral contraceptives, that's a possibility, non-steroidal anti-inflammatories, anti-fibrinolytics. I'm not supposed to mention that or whatever, I had to do my disclaimer on that. Anti-fibrinolytics are possible. You can't get them, but every textbook you read talks about them. And then surgical management. Now, how do the progestational agents work? Well, earlier we talked about the PGF2 alpha and the PGE needing to be in the right ratio. But progestational agents also inhibit the synthesis of estrogen receptors. So if you can block it at the cellular level, that's very effective. Progestational agents promote the conversion of estradiol to estrone, which has less effect, and it inhibits LH, luteinizing hormone. Progestational agents also organize the slough of the endometrial lining at the time of menstruation down to the basalis layer so you don't go past that and bleed more. And, as we mentioned earlier, progestational agents stimulate arachidonic acid, which then promotes the improved PGF2 PGE2 ratio. I apologize for showing you this pathway, but arachidonic acid, as I mentioned, goes to PGF2 alpha, which then splits off to prostacyclins, which promotes vasodilation and inhibits platelet aggregation, and thromboxane, which inhibits or which causes platelet aggregation. Now, with the adolescent patient with abnormal bleeding, they're ideally suited for progestational agents. However, they will say, it causes me to gain weight. And that's hard to argue, but there are no calories in Provera. It may affect the appetite centers, but it's worth it to tell them it could affect your appetite. You need to be vigilant about what you eat and so forth. But it doesn't affect the immature hypothalamic pituitary axis. So you can use Depo-Provera in a 13, 14-year-old age patient. They're the preferred agent for women who have anovulatory abnormal uterine bleeding because it's anti-estrogenic. So we would urge you to consider a progestational agent in those women. Cyclic progestational agents don't really help a lot. You can try it. If it works, great, but it's probably not going to help a lot. Now, progestational agents are found in medroxyprogesterone. You can write a script for that orally, 2.5 to 10 milligrams daily. You can do it cyclically. First 10 days of every month, last 10 days of every month. You can take it continuously. You might be able to use progesterone in oil. That's still available, not commonly used, but you can still get it. Depo-Provera, 150 milligrams IM every 3 months. If a patient begins to experience bleeding before the 3 months are up, you can make it every 2.5 months. So you can advance that a little bit safely. You're not going to cause any harm. And then the levonorgestrel IUD. Those are very, very effective for managing abnormal uterine bleeding, and I'll share some data with you on that. Consider a progestational IUD. There's 2 of them on the market. I won't mention their names. Their initials are Manera and Progestasert. Very effective for abnormal uterine bleeding, provided you've ruled out other causes and malignant process and a pregnancy. The levonorgestrel releasing intrauterine system has been studied. In this recently reported article, it was a retrospective review, and they found that 68% experienced improvement in menorrhagia. It is effective. I've used it successfully. My patients, as well as myself, have been very pleased with it. In a randomized 3-year study that was reported in 2004, they compared the levonorgestrel IUD group with a resection group, women that underwent resection of the endometrial lining, and blood loss subsequent was the same in both groups. Patients were very happy. Now, if you have a patient with endometrial hyperplasia, that's not malignant, no atypia, you can initiate a progestational agent if you don't have atypia. In fact, you should initiate the progestational agent. And you can use Provera 5 to 10 milligrams daily, or you can go with the Manera, whatever you choose to use. Now, estrogens can be given for the acute phase. If a woman's having acute abnormal bleeding, you've ruled out malignant process, or you're doing an EMB at that time, it's reasonable to give her estrogen. If it's an acute bleed and her hemoglobin's starting to drift down into the 6 to 7 to 8 range, you can give her IV estrogen. It's very effective. Sounds counterintuitive because she's had long-standing anovulatory bleeding and you're giving her estrogen, but what it does is it promotes rapid healing of the endometrial lining, seals off the bleeding, then you need to initiate the progestational agent. So you can give 25 milligrams IV. You can give that every 6 hours. Within 24 to 36 hours, the bleeding will have stopped. Gives you time to initiate blood transfusions, come up with a longer-term plan. If the bleeding isn't that severe, you can give it orally. So you can give them the yellow pills of Premarin, which is the 1.25 milligrams, and you can give them 4 of them 4 times a day, and that's enough to stop the bleeding, usually within, again, 24 to 48 hours. Birth control pills will accomplish the same thing. You may get some nausea with that, though, because they're so very, very potent. So 2 of the yellow tabs 4 times a day. That'd be 10 milligrams. Now, non-steroidal anti-inflammatories are an effective treatment for menorrhagia that's not taking on a life of its own. Studies have shown that non-steroidal anti-inflammatories will diminish vaginal bleeding by up to 40%. They take 400 milligrams of Motrin 3 to 4 times a day prior to the onset of menses, and it will decrease bleeding to a certain extent. If it's just a little bit and it's putting the woman over the edge, she may very well be very, very happy with that. Now, as you know, non-steroidal anti-inflammatories block cyclic endoperoxides, which facilitate the production of prostaglandins from arachidonic acid. They're not selective for prostacyclines or thromboxanes, but when things are blocked, they inhibit the vasodilation and the inhibited platelet aggregation that the prostacyclins are responsible for. But it's not specific, but it nonetheless provides relief. I mention these only because you'll see it in textbooks. You can't get them anywhere. The cyclocapron is used. It's indicated for hemophiliac patients undergoing dental extractions. Dr. Hurlbert, are you aware of anybody in our institution providing that for hemophiliacs? No, I'm not. Surgical options: laser ablation, thermal ablation, resection, or hysterectomy. That would be the final resection. In comparing laser resection versus thermal, total satisfaction is very, very high in both. Now, I have a case that I managed this past 6 months. Very fascinating case. It's a 45-year-old woman who presented, and this won't be in your slide pack because I just uploaded it recently. It's a 45-year-old woman presented with a history of postmenopausal bleeding. She was treated for breast cancer in 2004 with chemotherapy and radiation therapy. She was estrogen receptor negative, progesterone receptor positive. She was not given tamoxifen for adjuvant therapy. Subsequent to her chemotherapy and radiation therapy, she became postmenopausal, no further bleeding, hot flashes, vaginal atrophy, so on and so forth. We couldn't manage it with hormones because of her primary breast cancer. 2006, she presented with vaginal bleeding. So, your evaluation, ultrasound. You'd want to get that for sure, right? So, here's what the ultrasound showed. Oh, you want to get labs too. And what else would you want to do? Endometrial biopsy. Very good. All right. Now, ultrasound showed a cystic endometrium, likely secondary to tamoxifen therapy. Endometrial stripe width 11 millimeters. But this woman wasn't on tamoxifen. And the actual report showed multiple tiny cysts in the lining of the uterus. It smelled of cancer. And with her history of having a primary adenocarcinoma of the breast, we were very concerned. Labs, FSH 15, TSH was normal. Endometrial biopsy, secretory endometrium, no evidence of hyperplasia or malignancy. Now, I've known this woman now for about 3 years. She's just a lovely patient. She and her husband come in and got one of the best attitudes I've encountered in many, many years. And I'll tell you a little bit more about that. So what's the diagnosis? She's ovulating, very good. She recaptured ovarian function, and that's evidenced by the FSH being normal and the pathology report demonstrating secretory endometrium. In summary, think coagulation defect in the menarchal adolescent patient with severe menorrhagia. Remember, 20% of those patients will have a primary coagulation problem, and that's most commonly von Willebrand's. Incidence of about 1 in 1,000. Gestational events, pregnancy, are the most common single likely cause of abnormal uterine bleeding in a reproductive age woman. Think pregnancy. Again, even if she's had a tubal, husband's had a vasectomy. 35 years and older, abnormal bleeding, knee-jerk reaction, endometrial biopsy. Never let a 35-year-old woman or older go out the door with a history of abnormal bleeding without doing an endometrial biopsy, particularly if she's obese or has any of the risk factors for endometrial cancer. And if you're going to prescribe estrogen, be sure to screen for the contraindications: active liver disease, active coronary artery disease, undiagnosed vaginal bleeding, breast cancer, thrombophilia, history of blood clotting. Be aware of those things. Levonorgestrel IUD is an excellent means to control abnormal bleeding. And again, the most common cause of abnormal bleeding in a postmenopausal woman is atrophy. 10% will have a malignant process. Transvaginal sonogram is an excellent screening tool for the evaluation of postmenopausal bleeding. Where I use it is if I have a woman who has a stubborn cervical os, she's not a good operative candidate to have a DNC, and I get an endometrial stripe width of 3 millimeters with just one episode of abnormal bleeding, I will follow that patient expectantly, very closely, have her come in every 3-month intervals with the understanding that if she has no further bleeding, then we're done. If she has another episode, then we notch it up, go to the OR, and do the DNC. Women with recurrent postmenopausal bleeding need definitive follow-up. The endometrial cancer risks, of course, age, obesity, unopposed estrogen, diabetes mellitus, and elevated blood pressure. And of course, those are all co-linked. And recent reports have demonstrated upstaging with hysteroscopy and endometrial cancer patients. The question is, what does obesity have to do? And the primary cause would be the anovulation that goes with that, which then results in unopposed estrogen. That's the primary link. The question is, does it also involve the fact that fat tissue has more estrogen? Yes. Adipose tissue is a repository for the estrogen, so that's probably a factor as well. Good question. How long can you use the Premarin to control the abnormal bleeding? What I usually do, if it's an acute type phase, I'll have them on Premarin for about 2 to 3 weeks and then initiate the progestational agent. But you have to be very careful not to let that patient fall through the cracks and have unopposed estrogen for a long period of time.
And I mean, I presume that there's sometimes when you may not have ruled out other causes where you use it to control the bleeding and then come back and rule out the other causes. Is that correct?
Yes. What I will almost always do is do the endometrial biopsy the day I see the woman, recognizing that it may cause me to backtrack and stop the estrogen. But you're not going to make a underlying endometrial cancer that's a grade 1 lesion run rampant with 2 to 3 days of the estrogen. Because if you think about it, she's had unopposed estrogen for years, and that's what's resulted in the altered pathology. So 2 days of estrogen, you're not going to do any great harm, but you want to limit that. What's the risk of a thrombotic event? It would be minimal, but be cautious if the woman's not ambulatory, if she has risk factors, if she has stasis, Certainly if she has a history of a thrombotic event, that would not be an option for you. If she's had a stroke, prior pulmonary embolus, or thrombophilia, something of that nature, then that's a woman you would not want to use it in.